اوكي بسم الله الرحمن الرحيم وصلى اللهم وسلم على رسول الله الكريم. اللهم اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا به قولي. اما بعد, thank you very much for joining for this lecture. Inshallah, we're going to talk about persistent pulmonary hypertension of the newborn. I have no financial disclosure. We're going to describe the PPHN. We're going to talk about physiology, pathophysiology, clinical manifestation, and diagnostic approach. And finally, we're going to talk about management and long-term complication or sequence of the PPHN. زي ما دكتور أيمن معلش في كانت دير سايلنت للشخص اللي فاتح المايك.
ديرني كوهوست دكتور أيمن.
أنت المفروض ماشي. وينك أنت دكتور أيمن؟ أنت خاش بأيمن. أوكي أوكي you are co-host إن شاء الله.
تمام.
Okay, so full-term baby, they call you for emergency C-section. You discovered that, or they told you there is meconium at time of delivery. Had a very common scenario that almost all of us, we're gonna go through it. Baby, as you can see, you can see some retractions. Baby is highly tachypnic, distressed. You start bagging the baby, you deliver CPAP, and baby still mild or moderate respiratory distress. You can see covered with the full meconium. Start DSATs, he's saturated in the 85%. Highly tachypnic, highly distressed. So as we can see here, the case is very straightforward, full-term baby. And we said that this baby born by C-section, and we said that there is meconium. Before even you go for any delivery, there is always expectation, correct? We discussed about in the respiratory distress. We said the baby full-term go for delivery C-section. My first differential diagnosis could be transient tachypnic newborn. As we discussed, just reminder, it's easy, very good to go over. We said that the lung full of the fluid, around 1/3 of the fluid starts absorbed by the contraction when the mom has a labor, all her hormones, thyroid hormone, cortisone hormone, epinephrine, everything is go up. So that's open the channels, sodium, the water start absorbed. Second 1/3, it's combined of the peak of the labor and the birth canal mechanical factors, like you have sponge squeeze in. The third factors, or the last third, when the baby starts deliver, crying, hydrostatic pressure, air come in, and the fluids start absorbed through the lymphatics, okay? A baby born by C-section, especially if it's scheduled, we said it's very highly likely that baby gonna lose the first third, second third, so there's high chance he might end up some retractions with mild respiratory distress. So that's we discovered this topic. We said it could be other differential diagnosis. It could be sepsis or pneumonia. That's always in your differential diagnosis, although we can see there's no clear risk factors. But just giving the fact that there is meconium, baby see moderate respiratory distress, DSATs, I will always concern about pneumonia or sepsis. The third differential diagnosis, it could be, since we have meconium, it could be meconium aspiration syndrome. And we will discuss about this a little bit. And then other differential diagnosis that we have, it could be pneumothorax. Why? Because we bag the baby, correct? And we give the CPAP. It could be meconium with the CPAP that we deliver, and that might end up baby pneumothorax. Thoracic. What other differential diagnosis could be others, correct? That is not common, but can be. Could be congenital heart disease. Congenital diaphragmatic hernia. In fact, they called me last year when I was working in the level 4 period children, full term, all of a sudden, baby, they call us because baby meconium, not meconium, baby was severe respiratory distress. They have full resuscitation start, bagging the baby. They want a stat. I was running. No perinatal care. We couldn't know why the baby behaved like this, severely cyanotic. End up have congenital diaphragmatic hernia. A lot of centers here in USA, they have very good perinatal centers. So diaphragmatic hernia, usually we know long time, and everybody prepared. We know who's going to be the pediatrician, who knows going to be, sorry, neonatologist. We know the MFM, which maternal fetal medicine, who's take care of the mom. So we usually prepare the head. But sometimes if there is no perinatal care, the expectation can be there. Other cause could be congenital anomalies of the baby itself. Could be, we said, sequestration, pulmonary sequestration. We said that piece of the pulmonary circulation is covered with or supplied by the aortic or by the aorta, not by the pulmonary. So it could be baby has collapsed lung, atelectasis, and so on, so correct. So there is a lot of differential diagnosis you need to think about. It could be baby has surfactant deficiency, the RDS. We forget about it, it's very common. We said the surfactant can interfere with the, the meconium can interfere with the surfactant function, and we might end up having RDS-like pictures. So those your differential diagnosis, okay. But let's talk about meconium before we start talking about our topic. So if you have a meconium, okay, you don't have to remember or memorize by heart. It's very easy to remember. I'm going to draw a picture so it's easy for you guys to know. So that's our, I'm not going to draw pictures, but that's our airway. Sorry, you see? Right and left main bronchus, bronchioles, and then we have the alveoli, okay? So you have the meconium, and I will do it with yellow. So you have the meconium. It could be meconium come here and block the entire airway. Very big meconium block the entire airway, and that might end up collapse completely this area, correct? So that's number one. So what's gonna happen? You might expect it atelectasis. Collapse, either small portion or the entire left side or just piece. So we don't know, depending on where exactly located the meconium. Or it could be that meconium, the one we said, it can create one-way valve. So we know below the focal cord, during inspiration, the airway is open. During inspiration. During expiration, it's the vasoconstriction. Mike, please, guys. اللي فاتح المايك جاي من المايك.
لحظة هاي.
During inspiration, air come in. During expiration, air stuck because the vasoconstriction. So what's going to happen here? So here we said that collapse, but if we have one-way valve, what's going to happen to the airway? It's going to have the air trapping. So the air come full this area with the air, and what's end result? So you have air trapping, and end result is pneumothorax. Okay, so that's second option. Third option, the meconium is very small, go all the way and create something called chemical pneumonitis. Chemical pneumonitis. Okay, what else might happen? Meconium might go all the way, so that's the alveoli, and we say that comes here and maybe interfere with surfactant, correct? And then what we're gonna have, we might have RDS, yes, good. So we might have, sorry, RDS. surfactant. But the end result, all what we do, like when you have the meconium with maybe any of those respiratory distress, whatever the reasons, what we try to achieve or prevent, not to achieve, what we try to prevent something called persistent pulmonary hypertension. That's the true emergency. So like pneumothorax through emergency, the rest you can manage, but really all the causes that we mentioned, the end result, your goal to prevent persistent pulmonary hypertension. Is that clear? So let's go to the next so we can cover. So meconium aspiration, it can be obstruction, air trapping, either VQ mismatch or hypoxemia, air leak, or the pneumothorax. Chemical inflammation, chemical pneumonitis, or surfactant inactivation, RDS. It can cause atelectasis. Everything what we do to prevent persistent pulmonary hypertension. Is that clear? Okay. So before we mention what's persistent pulmonary hypertension, what happened, let's go to the fetal circulation. I'm gonna draw a nice picture, talk about fetal circulation. So everybody, or all of us, we're gonna be in the same page. So usually I draw the heart like box, and really everything is about this box. So if you memorize this box or you understand the heart, so here, the left atrium, that's the left ventricle, right atrium, and right ventricle. And that's the fetal circulation, okay? Here we have the aorta, here we have the pulmonary, there is ductus arteriosus, and here go to the lung, okay, for ventilation. And here all the way to the lower, through the aorta, sent to the entire body. And here you have superior vena cava. Here you have the inferior vena cava, but connected with inferior vena cava, let's have it different color. Connected to inferior cava, portal vein, and then umbilical cord. So umbilical vein, okay? And then here we have the pulmonary artery, or pulmonary vessels, sorry, not pulmonary, sorry, pulmonary vessels. We have tricuspid, we have the mitral. So let's talk about circulation. So we know that from the mom, oxygenated blood, happy oxygen, come here. So the way to work here, we have the foramen oval, okay? So the way the blood go, first go like this way and then go their way. So you have the flush, or the blood with the pressure comes. So here, higher oxygenation than on the right atrium. So left atrium, if you measure the oxygenation intrauterine, the left atrium versus right atrium, the left atrium high. Why high? Because the right atrium is mixed with the inferior vena cava, deoxygenated, sorry, superior vena cava. So it's mixed a little bit. Versus the right atrium, left atrium, you have the direct blood flow through the foramen oval, right to left shunt, and here more heavier oxygen, okay? But let's assume that's still heavy oxygen. Go to the right ventricle, and from the left atrium, go to the left ventricle, and then intrauterine, you have the pulmonary vasoconstriction, only less than 20% of the blood go to the pulmonary for the growth. So the lung is not working, it's just growing, filled of the fluid, okay? So the rest, where it goes? Indirect, we call the right to left shunt through the ductus arteriosus to the entire body. Here, go to the brain. So the blood go to the brain, higher saturation than the rest of the body. Again, intrauterine fetal circulation, that's the umbilical vein, portal vein, inferior vena cava, superior vena cava. Okay, so oxygenated blood comes immediately direct to the left atrium and the right atrium. Right atrium mixed with the inferior, with the superior vena cava. so slightly lower oxygen or saturated than the left atrium. Both gonna go to the right and left ventricles. As I said, less than 20% of the blood cross the pulmonary, go to the lung, and the rest is cross the ductus arteriosus to the entire body. Okay? So that's normal fetal circulation. Any cause or any reason or any parameter that cause hypoxemia make this one persistence closed, that's what's PPHN. So PPHN, it's occur when this one remain closed for any reason. We will talk about all the reasons that we mentioned, but we will talk about it more. Anything that make this one persistent closed, PPHN is gonna occur. So what happened after baby born? So before that, this area we called pulmonary circulation. And this side we called systemic circulation. Intrauterine, the pulmonary circulation higher than systemic circulation. Again, intrauterine, the pulmonary circulation higher than systemic circulation. Why? Because majority of the blood come from the pulmonary and there is valve, so the right ventricle has to pump the blood across the ductus arteriosus, so you need a lot of pressure. What happens shortly after birth? Shortly after birth, you cut the placenta, or sorry, you cut the umbilical cord, okay? Sudden drop in the pulmonary resistance because you take off the circuit. So that's number one. Number two, baby start crying because the oxygen come in. We said baby is born, he's gonna get oxygen. So what's gonna happen? Oxygen is potent vasodilator. So it's when the pulmonary reverse the vasoconstriction effect of the pulmonary. Plus the blood is gonna, so once this one start dilate with oxygen, the shedding of the blood start moving this way. The stress or the shed of the blood go through the pulmonary, release the nitric oxide, and the nitric oxide causes potent pulmonary vasodilator and further dilate. Plus the lung fluid, what happened? We said the lung absorb it, so that's gonna decrease the pressure on the pulmonary vasculature. So again, and we will talk about it more. You cut the cord. That's number one. So you decrease the pulmonary circulation or resistance. Sorry. Second, baby is gonna take air and fluid. Since mom, she has a labor contractions, either normal delivery or C-section, the fluid start absorb it. So let's tension on the pulmonary vasculatures. Plus the baby is taking air, potent vasodilator. That's help blood go through the pulmonary. And then once the blood reaches the pulmonary shedding of the blood, that release the nitric oxide, and nitric oxide has potent vasodilator. This one close within immediately to the first 72 hours of birth, a full-term baby, a week, 2 to 3 weeks if the premature babies. So then gonna be retained to the normal circulation that everybody aware. Okay. So what's the factor that maintain the pulmonary vascular resistance? Why we said the pulmonary vascular resistance is very high intrauterine? Number one, we said the lung is filled with the fluid. That's what we mentioned, correct? Baby live in the hypoxic environment. Baby live in hypoxic environment. Around 40s, the BO2 intrauterine, the baby oxygen, arterial oxygen is around 40s. So babies itself, he lives in the hypoxemic environment. Plus, you have the circulatory vasoconstrictions. There are some circulatory vasoconstrictions that contribute further to make the pulmonary vasoconstriction. You have endothelin 1, which is very potent vasoconstriction. There is two types, endothelin A and B. A cause vasoconstriction, B cause vasodilation. We are talking about endothelin 1, which is the potent vasoconstrictions. Some prostaglandin-like product, leukotrienes and thromboxane. That's why the non-steroidal anti-inflammatory drugs is not recommended on the pregnant, especially in the late trimester, because there is risk of the idiopathic closure of ductus arteriosus. What does it mean? That means there is some condition we call idiopathic closure of ductus arteriosus. Ductus arteriosus intrauterine, the ducts, it's closed. And baby usually born with severe persistent pulmonary hypertension and usually required ECMO. One of the conditions, although it's not proven in the studies, it's the non-steroidal anti-inflammatory drugs. Serotonin, also. The mom on the SSRI, which is serotonin reuptake inhibitors. SSRI, 1S, 2S, not 3S. Okay? SSRI, serotonin reuptake inhibitors. They said that SSRI during the last trimester increase risk of the persistent pulmonary hypertension. Why? Because it's increased the remodeling of the vascular blood vessel and cause primary or early or premature closure, of ductus arteriosus. Also, this one not proven, but theoretically. So those two is theoretically giving the SSRI in the late increased chance of the PPHN. The non-steroidal inflammatory drugs, also there's chance. That's why routinely they are not given or not recommended, but not proven. Okay, again, not proven. We said that endothelin 1 has potent vasoconstriction through the endothelin A. Chronic endothelin A receptor block in animal model resolve the pulmonary hypertension. Okay, decrease the right vascular hypertrophy, so no more pressure on the right ventricles. Decrease the vasculatures on the pulmonary, the muscular, and increase fall on the pulmonary vascular resistance. So the pressure on the pulmonary is decreased when you block the endothelin A receptors. Okay, and that's published 1997. This graph represents the mean airway pressure or arterial pressure by the time. As we can know, the green is the pulmonary arterial pressure. The red is the pulmonary blood flow. And the blue is the pulmonary arterial pressure. Sorry, systemic arterial pressure. So as we can see, intrauterine or the fetal, what happens? The pulmonary arterial pressure, the green, it's high. As you can see, the systemic is low. Or the pulmonary blood flow is low and systemic is low compared with the pulmonary circulation. Immediately after birth, it's reversed. The pulmonary drop, you can see the curve is drop. In fact, the pulmonary blood flow and systemic, it's increased. As simple as that, okay? There is some vasodilator reduced from the endothelial cells, like prostacyclin, I2, and nitric oxide. As I said earlier, the shear stress, just because increased blood flow through the pulmonary circulation, what's happened? An increased oxygenation also induced endothelium nitric oxide synthase to produce the nitric oxide. And nitric oxide is very potent vasodilator at the pulmonary, okay? More in the depth, so you can see that's the blue, the red is the endothelial cell. This one is the muscular, smooth muscle. In this endothelial cell, and that's the muscle, smooth muscle. What I need you guys to focus on, so as we said, the shear stress of just increased blood flow through the pulmonary circulation release the nitric oxide. The nitric oxide stimulate the soluble guanylate cyclase, which is turn increase the cyclic GMP, and that block the calcium. And once you block the calcium, you produce the vasodilator. Again, the nitric oxide stimulate the guanyl cyclase, which is in turn switch the GMB to the cyclic GMB, and cyclic GMB block the calcium production, and that's end up vasodilatation, pulmonary vasodilatation. The cyclic GMB go back to the GMB by the phosphodiesterase 5, and that's very important. And that's considered targeting medication because we use the sildenafil or Viagra that's block the phosphodiesterase E5, and that's maintain the high cyclic GMB, which is gonna continue block because it has short lifespan. So the cyclic GMB, when it start blocking, shortly turn back to the GMB by giving through the phosphodiesterase E5. By blocking this, remain the high cyclic GMB, which is continue blocking the calcium and persistent vasodilatation. Also, we discussed about the prostacyclin I2 work by stimulate the adenyl cyclase. The adenyl cyclase, the AC adenyl cyclase also, so adenyl cyclase convert the AMB to the cyclic AMB, and cyclic AMB block calcium production. The same way, the cyclic AMB short span go back to the AMB and through the phosphodiesterase E3, and that's also important enzymes because we have the target drugs that we use called mirelonone. Mirelonone block the phosphodiesterase 3. When you block phosphodiesterase 3, what happens? The cyclic AMB remain high, and that's continue block your calcium, and that's end up vasodilatation. Again, it's very important. Nitric oxide stimulate guanyl cyclase, which is turn the GMB to the cyclic GMB. And cyclic GMB block the calcium production, and that's vasodilatation. Cyclic GMB back easily to the GMB through the phosphodiesterase E5. Important enzyme, if we need to keep the cyclic GMB high level and maintain cause vasodilation, we need to block this enzyme using sildenafil. So we have two target medication. We're gonna use it. The sildenafil, the nitric oxide, mirelonone, prostacyclin I2. Those have good function, vasodilation. Also, there is strategic, we're gonna talk about it later on. You might block the endothelin 1. We said endothelin 1, you stimulate the endothelin A receptors, and that's cause vasoconstriction. Targeting medication that block the endothelin might end up the vasodilatation effect. Okay? So now, what's the cause of the persistent pulmonary hypertension? The cause of the persistent pulmonary hypertension, idiopathic in 10% of cases. That's number one. So you have 10%, we don't know what's going on. Why it happened? I have no idea. We don't know. They called idiopathic. The rest, any cause, any conditions that cause respiratory distress, hypoxemia, can lead to the persistent pulmonary hypertension. Again, any disease that we are aware of can cause persistent hypoxemia. This in turn can cause PPHN. So any cause of persistent hypoxemia can cause PPHN. So number one, Lung parenchymal disease. Lung parenchymal disease can be meconium, respiratory distress syndrome, pneumonia, sepsis, and here we discussed in the respiratory chapter the malignant transient tachypnea of newborn. If you have the transient tachypnea of newborn and you treat by giving, instead of treated CPAP and open the lung and let the fluid go away, you place baby on oxyhood, or you give oxygen, high concentration of oxygen, or you don't treat it very well. Oxygen, we discussed also last time, oxygen release free radicals, and that's more damage, toxins on the lung tissue, and that's caused persistent, in addition to the atelectasis already because of the fluid. Both can lead to the persistent hypoxemia, and that's end up PPHN. Once the TTN change and end up PPHN, we call malignant TTN. Okay? So, histological, the underlying cause, they divided the 3 parts. It could be mal-disposition, which is the all previous causes that we mentioned. It could be hypoplasia, any cause of hypoplasia, any cause of the lung hypoplasia. Like, everybody think, I'm gonna pause. What's the cause of pulmonary hypoplasia? Yes, oligohydramnios. If we have somebody or mom oligohydramnios, this risk of pulmonary hypoplasia. What else? She has a leak, rupture. What else? If we have mechanical, like what? Mom, diaphragmatic hernia. Yes. So if we have diaphragmatic hernia, can cause pressure on the lung and end up pulmonary hypoplasia. Correct? So those, it's called hypoplastic. The other, muscular hypertrophy, and that's the mostly hypertrophy, and that's histologically the PPHN, the cause divided in 3 different types: maldeposition or adoption, hypoplasia or hypoplastic, or the muscle hypertrophy. Some causes, they can cause more than one histopathology. The example of this one is the drugs like cisaridine. Okay. We have something called idiopathic. We mentioned about idiopathic also here. Idiopathic persistent pulmonary hypertension, or not idiopathic, the isolated closure of the ductus arteriosus, or idiopathic both. Isolated, mainly isolated closure of ductus arteriosus. The other causes of the PPHN, it's very rare. You can have the alveolar hypoplasia or dysplasia. You have the mutation in the surfactant. If you guys just remember, and that's refreshed, I like always repeat so everybody can remember and just move the information from short-term memory to the long-term memory. We discussed about surfactant. We get the majority of the surfactants made from the disaccharide or the non-saturated phosphatidylcholine. And we said that's the phosphatidylcholine. And then we said that around 20% or 30% or phosphatidylcholine, the non-saturated part, and then we said the component of the surfactant made from the protein, if you guys remember. So that's the, and that's, we said it could be protein, that's component could be protein, and we said there is 4 types of protein: protein A, protein B, protein C, protein D. We said that protein A and protein D, just remember the 2 outside, they are hydrophilic, that means water soluble, and they function as immune, and never been proven in cause in human, but in labs, yes, can cause RDS, severe RDS, but in human never proved. We have the B and C, protein B and C, that's mainly phosphohydrophilic, that means fat soluble. And we said that those protein, they are function as a surfactant. And in fact, a B at birth, that means baby can be presented with severe RDS started at birth, and usually lethal, that means baby dying because severe respiratory failure. And C, childhood, usually appear later on with the severe RDS, but usually during the childhood. And that's we discussed. So mutation in the surfactant protein, or we said it can be the receptors or the protein cascade called the ABCA3 deficiency. That's we discussed on the RDS. Also part of the, just to refresh about physiology, we discussed about VQ mismatch. We said that sometimes you have, so we have two components. We have V, which is ventilation, and we said the Q, which is the perfusion. You have to match the amount of the perfusion with the ventilation in order to have matched. You have to have matched amount of the blood flow to the alveoli and the amount of oxygen inside the alveoli. If you have poor ventilation or atelectasis, but good perfusion, that's called intrapulmonary shunting, and that's called mismatch. So it doesn't work. Baby gonna have hypoxemia. Also, if you are over-ventilate the baby, so over-expanded the alveoli, that's the alveoli, and squeeze the pulmonary vessels, regardless if you have normal supply of perfusion, still you're gonna have hypoxemia. So in order to reach the match, you need to good perfusion and good ventilation both in the same time. This one, I'm gonna leave it in the slide if somebody wants to review, but that summarize the underlying cause of the PPHN. All the causes start with the prolonged eruption of brain or renal malformation. We didn't discuss it. The baby had the fetal, had the Bott syndrome or any kind of the renal failure. Baby she might have history of the oligohydramnios that end up the pulmonary hyperplasia, which is end up PPHN. So now, how can I differentiate the PPHN from the other cause of the respiratory distress? So we said number one is going to be respiratory distress, correct? So baby going to be hypoxia and respiratory distress. So the moment I have dealing with that case of the meconium, baby has respiratory distress, I'm trying to give CPAP to open the lung, but I need to be careful because it might end up pneumothorax, or you give nasal cannula at the beginning until you have the x-ray. Whenever there's no right or wrong answer here, every practice is different, but you did the best, you did the x-ray, there's no pneumothorax, the x-ray looks ugly, more with the meconium aspiration syndrome, but baby is really hypoxia. The best characteristic of the PPHN, something called labile hypoxemia. What does that mean? That's the classical feature. That means baby sats fine, and then all of a sudden, drop the sats. That's called labile hypoxemia. So in baby with PPHN, they have cyanosis. There's 3 types of cyanosis that might contribute to PPHN. The most common, labile cyanosis or labile hypoxemia. Also, he might have central cyanosis. So why he might have labile cyanosis, why he might have central cyanosis, depend all about the picture that we draw earlier. So let's have the picture again so we can understand what's going on with this baby. So that's the left atrium, right atrium, right ventricle, left ventricle. We said this is the aorta and ductus arteriosus. This is the pulmonary artery. And we said inferior vena cava, superior vena cava, pulmonary vessels. Okay. And here there is foramen ovale. And here there's ductus arteriosus. Okay. So what happens if you have, Dr. Ayman, please mute. So imagine that you have the PPHN. So this area, it does not allow the blood to cross the pulmonary circulation. So what's going to happen? You're going to have the baby start breathing, the lung. There is no way to get oxygenation, and that's all the way down to the pulmonary circulation, correct? To the pulmonary vessels here. That's normal, comes all the way. But let's talk about, and that's unhappy oxygen, come from superior vena cava, inferior vena cava, go down unhappy, and then cross and unhappy. So here, let's assume the baby has some, you try to manage the baby, some oxygen come here, a little bit happier, not super happy, and then come here. And then you have the ductus arteriosus, correct? We said 90, around less than 20% of the blood go through the pulmonary, through the ductus arteriosus. So if you have unhappy oxygen, what happened? If you have unhappy oxygen, go to the mouse. It's not working. Okay. So unhappy oxygen come to the cross the ductus arteriosus, go here, and you have so ductus arteriosus. Sometimes what happens, it's the contraction open close open close open close, because we said temporary baby should be closed, the ductus arteriosus, immediately after birth or the first 72 hours after birth. What's caused labile hypoxemia is the ductus arteriosus, because the ductus arteriosus at the moment baby starts fine because this one's slightly vasoconstrictions and the baby is saturated fine, and then all of a sudden this open and the babies get deoxygenated blood, and that can give you labile cyanosis or labile hypoxemia. Differential cyanosis, and that's clue in your physical exam. If the ducts remain open, what happened? The upper part of the body, we said the brain and the upper extremities get still happy oxygen, so still saturated, good. The lower part of the body, he's saturated, not good, because of the blood from the pulmonary circulation cross the ductus arteriosus, go all the way to the through the ductus arteriosus all the way down to the lower body. So when you measure the pulse oximetry, either by looking at the baby before even you look at the pulse oximetry, but sometimes it's difficult because baby meconium is hard to see, or baby bale. If you measure pre and post ductal saturation, again, if you measure pre and post ductal saturation, you will see in the pre-ductal saturation, and when we said pre-ductal saturation, where it's supposed to be? Is it supposed to be in the right hand or on the left hand? Yes, good. So on the left hand. So when you measure the pulse oximetry on the left hand and you measure the pulse oximetry on the either right hand or the lower extremities, you will see a difference in the saturation. Any difference more than 10% saturation difference, that's enough to be significant. Again, so we said labile cyanosis or hypoxemia because some blood shunt and sometimes not shunting, that's intermittent, that's give you difference in the color. Differential cyanosis, if the ducts is wide, remain wide because of hypoxemia, the blood supply cross from the pulmonary circulation all the way go down to the body, and the upper extremities, the heavy oxygen go to the, so you have the difference. In the upper, it's oxygenated. In the lower, it's cyanotic. When you measure the right, left arm, or the pulse oximetry on the left hand versus the rest of the body, you will see that a difference more than 10. And that's why it's very, very, very important when you note that your baby is persistent hypoxemia, he required very high setting on the vents, he's not improved, you have to ask your staff or your nurse to measure the pulse oximetry on the left hand and legs, on the foot and the hand. Which hand? Left, not the right, the left hand, and anywhere the other, either right hand or the right foot. If the more than difference more than 10, you know that your baby most likely has persistent pulmonary hypertension, and that's true emergency, because if you don't fix it, baby might die. The central cyanosis, what happened? Why some cases you might have central cyanosis? Central cyanosis if your duct is closed. If there is no ductus arteriosus, let's assume example the premature closure of the ductus arteriosus. The baby premature closure of the ductus arteriosus. Sorry. So if the duct is closed, there's only way, so here, pulmonary vasoconstriction, there is no way for the blood to cross the pulmonary because higher pressure here. So the blood is stuck. It has to be either through the VSD or the foramen. So if there's no, then this baby gonna be completely cyanotic, central cyanosis, because everything is blue. So if you have premature closure of sarcoidosis, or there's secondary pulmonary hypertension, you have a premature baby who's 23 week or 22 week or 24 weeker, who has been chronic lung disease, and then somehow later on the history, he developed hypoxemia, the lung is very bad, and he at risk of the pulmonary hypertension. At the time, the ducts is already closed. So that baby, he's not gonna present with differential cyanosis because there's no duct. He's not gonna present it with the labile cyanosis. The only way he's gonna present with what? Central cyanosis. Hopefully that's clear picture. So how can I diagnose? Number one, clinical at the bedside. You're gonna measure the left pulse oximetry on the left hand versus the postductal, either right hand or lower extremity. Okay. Hyperoxic test, it's subjective. We don't use it. You can use it if you are in the center. There's no stat echo. There's no one can come and do the echo for you. Like for example, in the Libya, cardiologist is not available. It's very hard to call and call. You are in the small NICU, private. There's whenever the reason you have no clue, then you can do hyperoxic test. Here in America, we don't do it. Okay, because subjective is just twist more time. You rather call cardiology stat. He's gonna come and he's gonna do echo and he's gonna come with a conclusion. The others, chest X-ray, to rule out other cause, pneumothorax. If you just to confirm that what's underlying cause, if the lung clear or the lung it's the not clear. So if you have true PPHN, how's the X-ray looks like? Black, correct? Because there's blood complete vasoconstriction. You have persistent pulmonary hypertension. There is no way the blood gonna cross. Very few. There's not completely, but there is no. They called oligemic. Okay, oligemic X-ray, and I have X-ray. Where is it? We will come with that later on. Oligemic X-ray. But also it can be to rule out other cause. If there's RDS, you can see it. If there's Meconium aspiration syndrome, you can see it. If there's fluid level, you can see this, the TTN. If there is pneumothorax, you can see it. Also, if there is diaphragmatic hernia, that's clearly you can know the cause. Then you can call for ECMO. You don't waste your time. Blood gas, just to evaluate the severity, and lactic acid, tissue perfusion, and you see if how bad the acidosis. And usually they will have respiratory and then metabolic acidosis as well. CBC blood culture, you're gonna do it because baby respiratory distress, you don't know underlying cause, sepsis, or pneumonia, still on your top differential diagnosis, because everything can cause PPHN. So yes, you know that you are dealing with the PPHN, but PPHN is not, it could be idiopathic, it could be isolated closure, but everything can cause PPHN. So you need to figure what's the underlying cause. Why does my baby develop PPHN? What's the cause? So sepsis, you can treat it with antibiotics. So hyperoxic test, you give baby 100% oxygen. 10-15 minutes, you measure the arterial oxygen, or you can do either saturation, you look at your saturation, or you do BaO2. And if the normal, the oxygen is around 80, correct? So that's average, 60 to 80, we said normal, the BaO2. If you give 100% oxygen, you expect it to go above 300. So that's normal. Just too easy to remember, if it's normal, it should be improved immediately up more than 300. If baby remain less than 100, then you know that you're dealing with the cardiac. In between, it could be PPHN. It's the above 150 to 300, that's more of the respiratory cause. Again, above 300, you are more normal. If baby not improved, still very low, less than 100, that's cardiac. In between, it could be pulmonary or PPHN. So if it's just a between in the lower side, more toward the cardiac, then you think of the PPHN or mixing cardiac. If it's toward the normal slightly, which is above 150 to 300, that's more with the respiratory. Okay? You don't have to remember this. The golden standard to diagnose PPHN, it's echo. So what you're going to see in echo. So imagine that's the same box that I draw. So imagine that you have the high pressure here, vasoconstriction. So higher pressure here. So just you don't have to remember this picture. So easy. Number one, you're going to have the shunt is going to be what? You're not going to see left to right shunt. That's wrong, correct? You might see it in a situation where you have ductus, but normal, we said that shortly after birth, the systemic circulation higher than pulmonary circulation. So yes, normally, if I'm gonna stick the echo on the babies shortly after birth, a few hours after birth, I might see left to right shunt, left to right shunt. But in the condition where I have immediately after birth or condition where I have the severe PPHN, I will see right to left shunt, right to left shunt. So number one, that's number one. The direction through the ductus. Also the direction through the foramen ovale. Intrauterine, the foramen ovale, it's one-way valve. Sorry, one-way door. So that means only open in the right to left. You cannot open left to right because when the baby born, when you cut the cord, the pulmonary pressure, the systemic circulation increase, then the pressure increase here, the door is closed. There is no way to mix. But in the condition where you have the persistent pulmonary hypertension, the right side of the heart, the pressure is very high, then you will have what? The duct's gonna be remain open, and you will have the right to left shunt through the foramen ovale. So that's number two. Number three, that's called velocity or the jet through the tricuspid valve. The blood, because higher pressure here, blood is gonna be return jet through the tricuspid regurg. Velocity, they measure it. Also, the interventricular septum is no longer flat or like this. It's become bulging. Okay? Septum, the right ventricular septum become bulging because of the very high pressure on the right ventricle. Okay? The cardiologist also, he's gonna measure the pulmonary pressure, and he will tell you pulmonary pressure equals systemic or pulmonary pressure higher than systemic. If he said higher than systemic, then you know that's severe PPHN. Almost systemic, that means it's high. Normal should be systemic more than pulmonary. That's normal after birth. Is that clear, inshallah? Okay.
تمام دكتور ايمن، بارك الله فيك. عندي بس بنقول لك حاجه، مرات الانميوت يعطل معي شويه، فهذا علاش تسمع المداخلات مرات. اي تمام.
AA gradient versus the so what's AA gradient? The alveolar. So we know that this is the alveoli. That's the pulmonary. The measure the gradient between the alveolar arterial gradient. That's the we don't use a lot. That's the for people they want to memorize for the USMLE. But what I need you guys to know, if the AA gradient more than 600, that's one indication for ECMO. Theoretically, we don't use it. It's not practically used, okay? What's practically used? We use the oxygen index. And we discussed the oxygen index is the predict the oxygenation. And we discussed about hypoxemia or versus hypoxia last time. We said hypoxia, it's really reflect to the tissue level. It's the three factors affecting my tissue level or the hypoxemic level or cause hypoxic. We said number one is the BaO2, or we measure the saturation And we said this is more accurate, not more accurate, more practical use. Actually more accurate, yep. The second, we said the hemoglobin content, because the hemoglobin carry oxygen. So if you have anemia, then baby gonna have hypoxemia, especially severe anemia. You're gonna have tissue hypoxemia, tissue hypoxia, not hypoxemia, sorry. Or we said the number 3, so we said the oxygen, we said the hemoglobin, and what the other factor that we discussed the last time? The cardiac output, correct? So the heart, the pump. So those affecting my tissue hypoxia. In order to evaluate how far your baby hypoxemic, the best predicted for the high tissue hypoxemia, and that we use practical, it's called oxygen index, which is this equation. You take the map. How I know the map? Through the ventilation, most likely those baby on the ventilation. So the ventilation itself, it's reading the map for me. You multiply how much oxygen you give to your baby, the fraction of oxygen, divided to the arterial oxygen, the BaO2. And you can see the color here. Normal or the mild should be less than 15. 20 to 25, that's indication for nitric oxide. If more than 20. More than 40, it's indicated for ECMO. That means you need to have your baby in ECMO because he's not gonna be resolved. So that means severe hypoxemia or hypoxia, sorry. Is that clear? MAP multiply FiO2 divided by the BO2. Okay? That's the X-ray. You can look at the X-ray. This first, when you look at this X-ray, you can see the very dark X-ray. That's called oligemic lung. And that's indicated less blood supply to the lung tissue. And that's indicated, Shani, the degree or indicate baby has PPHN, sorry. Another X-ray just to make you guys think what's going on. You can see that's the NG. And we said always when you do X-ray, never pay attention why you are looking for X-ray. So for example, if you do for the lung, always look at the others before we jump in the lung, because that's very clear X-ray, correct? But there's a lot going on in this X-ray. Number one, if you look at the lines, your endotracheal tube deep. How can I deep? Because you can see it's the, let me take it off the color so you can guys pay attention. You can see it's deep in the right mainstream. Okay, that's the carina here. Number one, just by looking at, make sure there's no fractures. Make sure the NG, because we said the line, so we discussed about the endotracheal tube, we need to adjust it. The NG tube, you can see, go all the way to the lung. That's indicated there is diaphragmatic hernia, correct? And you can see bubble, and that's most likely the bowel. Okay, so that's that congenital diaphragmatic hernia. So now we know that my baby has PPHN, severe respiratory distress, whenever the reason, either meconium, sepsis, TTN, whenever the reason. I didn't manage very well. Somebody didn't manage very well. You came in during the shift. You find your baby persistent hypoxemia. He told you already, I did everything, still hypoxemia. The first come in your mind, is it cardiac or PPHN? How can I know? I'm going to measure the pre and post ductal saturation, this number step. It can help direct you, support your diagnosis. And then you have to request stat echo because that can differentiate whether cardiac or PPHN. Why why it's very important? Because the management strategy is completely different when you deal with the PPHN. Okay. So first, it's very important to early recognize the PPHN. So always you have that low threshold for PPHN. Every time they call you for high risk delivery, you're always keep in your mind that PPHN, hopefully my baby doesn't go to the PPHN. If they call you and they said baby in the mom's room and he's distressed, something you need to think about it. Oh, he might be stay for a long time and nobody discovered it until late. I need to make sure my baby is not in PPHN because it can be mild PPHN, moderate, and can be severe PPHN. And then we said is always we're gonna try non-invasive before we jump to the invasive. So first of all, in management, after we recognize the condition, is to give the supportive care, to make sure that he's warm, to take off the stress from the baby, because he already on the stress, internally stress, you don't want to add external stress. So you need to optimize the temperature. You need to deliver the good nutrition in your baby, and you want to avoid the hypotension. If your baby is dehydrated, or if your babies have low blood pressure, you need to fix it. You need to try to minimize the irritation, cover the baby eye, minimal noise, less people in that room. If you need, and a lot of them, especially in the severe cases, they need some sedation, analgesic. So use either morphine or fentanyl. You can use also Fetal, which is the midazolam. Anti-anxiolytics that's going to help baby calm down. Always, always, always remember, paralyze the baby, increase mortality. Paralysis, increase mortality. Meconium, all those medication can increase mortality, okay? So try to avoid unless it's needed, really needed. So what you need to do, quiet room, less disturbance in the baby, dark. If you turn off the light, so it's be less irritation. If you don't wanna, if you wanna see everything, you can cover baby eye. Control the temperature, place the lines, use the central lines because this baby gonna stay, so you need the UVC. You might need the UA line. If baby severe enough, you place the UA line because you need to draw a lot of flaps. So that's the first supportive treatment. Still, we didn't discuss about the actual treatment. So then the question is, what's my goal of the oxygen? As we discussed last week, there is no true answer for this one. Most of the literature, they said, and the textbook, they recommend the oxygen to be 90 to 95, no more than 95. And I will say in why. 90 to 95, you wanted to avoid hypoxemia. So your goal, it should be 90 to 95. Why we don't want to give 100? Although widely practiced in America, a lot of physicians, they use higher, 95 and a half. That's automatically PPHN 95 and above. That's been practiced, traditionally practiced, and still practiced until now. A lot of centers, that's the goal. But if you look at the textbook and the literatures, they recommend 90 to 95. The reason why, based on the lamb, newborn lamb study, they give lamb 100% of oxygen, and they found with 100% of oxygen, baby has rebound pulmonary vasoconstrictions. So where is it? Rebound vasoconstrictions. Also, after they give 100% of oxygen, when they start nitric oxide, they found that the baby respond less on nitric oxide than when you give. So if you treat baby normal, target 90 to 95 versus 100% oxygen, when you start after 100% nitric oxide, the response to the nitric oxide is less on those baby on 100% of oxygen. Make sense? So that's based on the study. Most of the literature shift toward 90 to 95, just because number one, rebound pulmonary vasoconstrictions on 100% oxygen, and then the response to the nitric oxide after you give 100% is less expected, less response, vasodilation, less likely to develop pulmonary vasodilatation than if baby in regular circumstances. In addition, the oxygen, again, oxygen aid medicine, release free radicals, and that's cause more damage, okay? Okay, so treatment strategy divided to two strategies. So draw a picture again, just to keep everybody awake. I know you guys fasting, you just break fast, full of stomach. Blood supply go mainly stomach, so we need to bring it back. So we have superior vena cava, we have inferior vena cava, pulmonary circulation. So your goal, so here we have higher, here we have higher pressure, correct? So do we have higher pressure? So my goal is, number one, I'm gonna decrease the pulmonary pressure. Oops. decrease my flow on the pulmonary. So I'm going to decrease my pulmonary vascular resistance so I can improve the pulmonary circulation. That's the goal. The second goal is the increase systemic. At least increase systemic, make more pressure here. It might reverse that vasoconstriction effect. So the goal is to decrease my pulmonary vascular resistance pressure by increase the pulmonary flow or increase the systemic pressure that might overcount the pulmonary vasoconstriction effect or pulmonary pressure. So I need بالعربية نبي البريشر على left side higher than the pressure on the right side. Pressure on the left side, I need it higher than systemic, higher than. How I make it? Either increase my systemic blood pressure or work to decrease my pulmonary blood pressure. Is that clear, inshallah? Hopefully it's clear. Let's go. So how can I increase the pulmonary flow? I need my pulmonary flow to increase by giving, number one, oxygen at the beginning. We said oxygen. The goal for me, the oxygen, I didn't say 100%. We said we needed to be target oxygen, 90 to 95. So whenever is oxygen, give it to make 90 to 95, that's what I need to achieve. If you have arterial gas, I need my BaO2 55 to 80. Number two, I need to avoid or treat the acidosis. We have respiratory acidosis and we have the metabolic acidosis. There's two different. If I'm dealing with respiratory, I'm going to deal both, most likely initially respiratory, and then it's going to be both metabolic and respiratory. So here by the place maybe on the vents, either non-invasive and then invasive, we can discuss later on about strategy of the vents. If I have the metabolic acidosis, I need to fix metabolic acidosis. Baby need fluid, I need to give fluid. And tetra, okay? Surfactant. What's the rule of the surfactant in the PPHN? There is a huge rule of surfactant in PPHN because we know surfactant can improve my recoil. It's gonna recruit the collapsed alveoli. And if you remember the picture VQ pictures that we mentioned, if we have collapsed alveoli, it's gonna have VQ mismatch. So I need to return it to the matching VQ match by giving surfactant. Which condition I need to give it? If the cause of the PPHN is the RDS, or if the cause of my PPHN is the meconium aspiration syndrome, because we know meconium aspiration syndrome can miss or displace the surfactant or inactivate my surfactant. So I need to give the surfactant trial or give surfactant might help recruit the alveoli, and that's overcome from or help the VQ match. Or if I do with the sepsis and I know that certain conditions, sepsis can inactivate my surfactant. Okay, just refresh you guys, multi-study, look at early administration of surfactant and lung recruitment is associated with better outcome and reduce the risk for ECMO. Reduce the risk for ECMO. So surfactant, early administration, always think about it. If you have PPHN and you know that meconium most likely, that's what we deal. And we used to have a lot of the PPHN babies. But now we don't see that common because of the early delivery. They don't leave the mom until post-date. They induce her early, they don't late. If she doesn't show up, if she doesn't have a contraction, they start inducing her because the meconium is treated mainly with the post-term. So that's why we don't see that common. Okay? Then mechanical ventilation. So if we place baby on if we decided to intubate the baby have severe PPHN, your goal is the low lung strategy. The same like COVID now, they're talking about low lung strategy, the same. Like ARDS, the low lung strategy. So normal, I would like my lung expansion to be 8 and 9. I don't want to over distend. So the goal is to prevent volutrauma or barotrauma. Whenever I use volutrauma, barotrauma, I need to avoid both volutrauma and barotrauma. So gentle ventilation strategy, what does it mean? I need to use the optimal beep to open the alveoli, lower my PIP or tidal volume that I'm using, and like what we said in the babies, premature baby, I'm gonna allow full-term baby to have permissive hypercapnia. What does it mean? The BCO2 between 55 and 65. So I'm okay to move the baby from full-term baby, which is the BH 7.35 to 7.45, the BCO2, and that's the easy to remember. The BCO2 is the BCO2 is the, what's the normal? 35 to 45. But in baby with PPHN, because how can I achieve 7.35 by going up on the vents? So I will let myself, I'm okay, I'm gonna adapt, it's fine to be on the high side, not super high, as long as my pH, it's more than 7.25. As long as my pH is more than 7.25, I'm okay. So that's called gentle ventilation strategy or low lung volume strategy. I'm gonna give optimal PEEP to open the alveoli, lower PIP or tidal volume, and some permissive hypercapnia. Now that's the recommendation for treatment of or ventilation treatment of the PPHN. The last time, because I know there is no jet or high frequency ventilation in the Libya, so I didn't go and I didn't discuss about high frequency. The high frequency ventilation, the way it's work, it's active. So it's like, I don't know. So the high frequency, the way it's work by, is not like the alveoli distension, in, out, distension, the alveoli increase, inspiration, expiration, like distension. The way it's work by vibrate, like vibrate. The air come in, you get CO2 out without distending the alveoli, without stretching the alveoli. So there's no active inspiration. There's no like normal what we do, like no like distend the alveoli like normal vents. No, we don't do this way with high frequency. High frequency, the way it's work and the jet, it's by recruiting the alveoli by vibrating, like the oxygen go this way, vibrating. Come back. It's not like the the ventilation, that's the norm. When you give air, distend it, and then exhale, inhale, exhale. That's the on the convention. On the high frequency, it's like vibrating, baby shaking all the way, and the air come in, the CO2 actively inhalation, passively taken off the CO2 by the jet, active and passive taken off the active taken in, passive taken out the oxygen. What the study? The study showed that high frequency compared with the effective high frequency. So they look at high frequency versus convention, okay? In baby of PPHN and respiratory, what they said, neither mode of ventilation was more effective in preventing the ECMO. Okay, so there's no one superior than the others in case of the which one is preferred on babies. But what is proven, okay, that high frequency in combined with nitric oxide has the greatest improvement in oxygenation in some babies who have severe PPHN. Okay, so babies who have severe PPHN, if you combine high frequency ventilation plus nitric oxide, you avoid ECMO and you improve the severe PPHN. Okay, another study, randomized multi-center trial study, the same baby on RDS, they found that, they found that high frequency and combined with nitric oxide decrease the need for decrease the PPHN, severe PPHN. Infant with RDS and Meconium benefit mostly from the combined high frequency and nitric oxide. The issue with high frequency, because of the shaking, the baby's full-term baby, they don't like it. So you need to give some sedation, because we said at the beginning of the management, we need to make the baby calm, taking out the stress, give him some sedation. If the baby is on the shaking mode, he might need higher dose, because you need to make baby completely rest while you're using high frequency. So a majority of us, we don't jump to the high frequency. You try first convention. If it doesn't work, when you maximize it, doesn't work, then you know that you're gonna give too much. And if you look here what they said, if you required the PIB more than 25 to 28, so usually we use the PIB of 20, correct? So if you require the PIB, PIB, the peak inspiratory pressure, if you required more than 25 to 28 range, higher, and tidal volume, we said normally around, we start 4 to 6 ml per kg of tidal volume. YVD, I don't know what this means. Tidal volume. Tidal volume. If you required more than 6, then you rather switch him to the high frequency, because again, the principle is simple as this. You need to avoid volutrauma, barotrauma, low lung strategy. If you find yourself up in pressure, farther up in pressure, or farther up on the tidal volume, you rather switch baby on the high frequency if you have it available. If you don't have it, unfortunately, you need to continue with convention, but you might sedate the baby, you might take out the breath in order to ventilate the lung, okay? There's always exceptions. So back just to give everybody the same. So babies, my babies, severe PPHN, I'm gonna dark room or cover the baby eye. I'm gonna start IV fluid and make sure that blood pressure on the high side. If he need volume, my goal is to prevent hypotension. My goal is to have central line. Everything is done. Baby on the non-invasive. He's getting worse. Intubate the baby. Give him sedation. Start on the convention. If it doesn't work, go high frequency. But before, so still baby does not improve despite baby on the certain PIP or certain tidal volume. Let's assume you start 4 ml per kg. He's not improved. You went up to 5. He's still hypoxemic. Then you measure your OI. You have your oxygen index measurement. We said oxygen index equal to the, just to memorize everyone, MAP, the mean airway pressure, which is already going to be measured, multiply my oxygen, FiO2, divided by the arterial oxygen, correct? It's easy. If we said more than 20, then I know my baby need nitric oxide. My baby need what? The nitric oxide. How looks like the nitric oxide? That's the nitric oxide. Not, I don't know. I don't think that you guys have it. I'm not sure. I will assume that you guys don't have it. That's why I choose the pictures. So the nitric oxide, it's different tanks. It's the nitric oxide. It's connected with the baby's vents. And you start always with 20. So let's talk about, we review what we said about how it's work. So we said the nitric oxide work by stimulation, reduced from where? From the endothelial cell, stimulate my guanyl cyclase. Where's my nitric oxide? Yep, stimulate my guanyl cyclase, switch GTB to the cyclic GMB. Cyclic GMB then block the calcium, and that's called vasodilatation. The GMB in return by the phosphodiesterase E5 come back to the 5-GMB. So we need to, what we need to do? So first you need to give the nitric oxide. How you start nitric oxide? There's something called rule of 20. What's the rule of 20? Number one, you start with, when we start the nitric oxide, if my OI, it's more than 20. So that's easy to remember. The dose, you're gonna order a 20 bar per million. 20 bar per million. I'm gonna go back to the image. You can see here, there's 20 number. So you start with a 20 pressure, the bar per million. In addition to that, mechanical ventilation. And that's the only medication that's been proven by the FDA and proven only for babies who's more than 34 weeks. Sorry, there's other medication, but this is the only proven to use if the baby more than 34 weeks. Premature, although we use it sometimes in severe hypoxemia, but not FDA approved. Okay? And we said that multi-center randomized controlled trial, nitroxide reduced need for ECMO in baby with PPHN. So you start with 20. In addition to the baby on the ventilation, you look at your number. Babies should improve immediately when you start baby on nitroxide, because nitroxide causes pulmonary vasodilatation. Once you place the baby on nitroxide, let's assume your baby, I'm going to give you 3 scenarios. Number 1, your baby improve. You can see start sats. You leave the baby alone a day or 2 on the nitroxide. Do not touch him until the pulmonary vasoconstriction taken away. And then after that, slowly you're going to start weaning the nitroxide. And we wean very slowly. So we start 20, drop to the 15, every 6, some centers, every center has different protocols. Some center every 6, some center you do every 12 hours. So depend on what you are trained. Okay, so 20, 15, 15 to 10, 10 to 5, and then 5 to 4, 3, 2, 1, stop it. Okay? While baby on the nitroxide, it's always measure methemoglobin level, because the nitroxide, baby on nitroxide at risk of methemoglobinemia. So that's why you keep measure the methemoglobin at least in the first 24 hours of life. Your baby improve when you consider weaning the nitroxide. You consider weaning the nitroxide if you start weaning the oxygen. So don't touch the nitroxide if you're still on 100% oxygen, which is 100%. I'm not talking about saturation. I'm talking about the FiO2 by the blender. If you are in the vents, your baby received 100% oxygen, and there is no way baby still hypoxemia. Then you do your OI, you start nitroxide. I start nitroxide, he sats now. He was satting in the lower 80s, assume 85. Now he starts satting in the 96 or 95. Then I know my goal saturation, we said 90 to 95. I will ask the nurse to wean FiO2 to keep the saturation between 90 and 95. But I will let her know, once you reach 60% FiO2, stop weaning the FiO2. Why? Because I need to wean nitroxide first. So once I reach the FiO2 below 60, then I'm consider weaning the nitroxide if my oxygen, arterial oxygen, maintained between 60 and higher for at least 60 minutes. So remember, now we said 360, correct? So below 60%, I start consider wean nitroxide. I have to look at my BO2 before I wean. If my BO2 maintains 60 millimeter mercury or higher for 60 minutes or 1 hour, then I know my baby ready to wean. Do we do it all the time, 60, 60, 60? The true answer is no. We usually just look at the FiO2. Once we reach FiO2 below 60, I ask the nurse, okay, hold on at 50% or between 50 to 60%, and then start weaning my nitroxide, because the nitroxide is very, very, very expensive. Again, very, very, very expensive. Okay? And I start weaning nitroxide 20 to 15, 15 every 6 hours, every 12 hours, depending on the protocol, 15 to 10, 10 to 5, and then 5, 4, 2, 1, and stop it. What's the side effect of the nitroxide? Platelet dysfunction, pulmonary edema because of the pulmonary vasodilatation, methemoglobinemia, and that's why we measure the methemoglobin level. Why we choose 20? We did not choose 30. We did not choose 40 because of the anything above 20 associated with more adverse effect like methemoglobinemia, and that's been reported. When you be careful, or what's the contraindication of the nitroxide? I'm gonna pause, I'm gonna take it off. I'm not gonna let you guys read it. So I need you guys to just close your eyes and think, what's the condition definitely you cannot use the nitroxide? Do you guys get it? So what's the condition that definitely you cannot use the nitric oxide? I'm going to explain. So back to the box. So it's easy so you can understand it. So that's aorta, pulmonary, we know, right, left, superior vena cava, inferior vena cava, pulmonary circulations. So if you have somebody who's dependent mainly on the left side, if you have patient who is dependent mainly on the left side of the heart, okay? If he has severe left ventricular dysfunction, when you do pulmonary vasodilatation, you drop pulmonary, then what's happened to blood? Systemic, what happens systemic? Is going to be increased, correct? Because you drop pulmonary vasodilatation. So what's going to happen? The small amount, because you have left ventricular dysfunction, whenever it's coming out, still is going to go to the right side, and more tiny who already have severe dysfunction, you're getting worse. So number one, if you have severe left ventricular dysfunction, you cannot use the nitric oxide. That's number one. That's why you need to echo to make sure that you are on the safe side. Number two, if you have left ventricular outflow obstructions, which conditions? Like you have severe critical aortic stenosis. The same way, correct? It's just minor 20% blood coming out from aorta. And now you give baby nitric oxide, you dilate this area, I'll drop the pulmonary, make systemic higher than the pulmonary, blood's gonna cross farther. So instead you have 40%, for example, 20% is gonna go systemic and baby gonna be shocked. If you have the hypoplastic left heart syndrome and tetra, okay? So that's clear. So the only conditions that you cannot give nitric oxide if you have something affect the left outflow. So you have either dysfunction or obstruction, okay? Very good. If the baby, we said the first case that your baby, you're able to wean, and we discussed about how you wean. The second condition, you stuck. Babies, each time you try to wean, it doesn't work. Each time you try to wean, babies desats, and you have to go back flow or back up on the oxygen. Then you might consider using the sildenafil, which is the phosphodiesterase 5 inhibitor, sildenafil. We discussed about sildenafil and we said how it works by block the reverse, because we said the nitric oxide stimulate the guanyl cyclase, which is GTP to the GMP. The phosphodiesterase, the GMP has short lifespan. Let's go back to the cyclic GMP by phosphodiesterase E5. The inhibitor sildenafil inhibit the phosphodiesterase E5, increase my 5 cyclic GMP, blocked by calcium, cause vasodilatation. So in case my baby does not, it's hard to wean nitric oxide, and I told you nitric oxide is very expensive, an inhaler, then I need to introduce the medication that help me taking over the nitric oxide and leave the baby on the sildenafil. So the sildenafil is oral or IV. So usually we use for chronic condition when the baby is already stuck, you cannot wean off, you have baby premature, he has pulmonary hypertension, you cannot wean, then you can use the sildenafil. So you use sildenafil while baby on the nitric oxide, and then you slowly taking away the nitric oxide. As simple as that, okay? The other conditions, if you have the baby with issue with baby has hypoxemia, as we know, if you have baby with persistent hypoxemia, the function of the ventricles might also be affected with hypoxemia. And if you did the echo, they said there is pulmonary hypertension, but also the ventricular function, it starts weak because of hypoxemia. Then you have the drug of choice, you might use it, which is called milrinone. Milrinone block my, I think is wrong, but you can double check. Minorenone, non like this, I think. Okay, minorenone, it's the block phosphodiesterase E3. We said the prostacyclin I stimulate the adenine cyclase, convert my ATP to the cyclic GMP. Cyclic GMP cause block of the calcium and vasodilatation. The same cyclic GMP can go back to the 5-AMP through the phosphodiesterase E3. So if you give minorenone, it's very helpful, increase the ventricular contractions, that's the function, increase my ventricular contractions, not vasoconstriction, okay? Ventricular contraction, contractility. But also can cause pulmonary vasodilatation. The issue with minorenone does not only selective pulmonary, also can cause systemic. So you need to measure blood pressure, make sure it does not go to the hypotension. Okay? So first strategy, we increase the pulmonary blood flow. We said oxygen is help increase the pulmonary blood, decrease the pulmonary or cause pulmonary vasodilatation. We said the nitric oxide. We talk about sildenafil and minorenone. The other strategy is my increase the systemic blood flow. My systemic blood flow or, my systemic blood pressure. How can I increase my systemic blood pressure? Again, systemic blood pressure, not flow. By, number one, treat hypotension or make baby blood pressure on the high side by increasing the afterload, systemic vascular resistance, using the vasopressor. Every hospital has different policy. We use the dopamine a lot in the NICU, but any of the vasopressor can be used. Okay? The third scenario, so we said a baby improve, you start wean. When the FIU2 reach, you start weaning, the nurse wean. You came back, you find baby in FIU2. He sets in the above 90s, the baby, the weans, the nurse, she said she can wean below 60s. You said, hold on, let me start weaning the nitric oxide. That's first scenario. The second scenario, baby stuck on the vents, stuck on the nitric oxide, give him time, day 2, 3, 4, 5, 6, 7, he's not improved, there's no way to wean, then you might call the cardiology, he might introduce the sildenafil, or that we will talk about other medication shortly. The third scenario, despite what you did, baby worsening hypoxemia, you measure the OI, and your OI more than 40. Again, OI, it's MAP, multiply my FIU2, divided my BaO2, and if it's came back more than 40, then you need to call the ECMO center or ECMO people. They have to come. If you are an ECMO center, they're gonna come, the ECMO team, they call ECMO team. They're gonna come. There is two types of ECMO. There is VV ECMO, veno-venous, which is the catheter introduced in the right atrium and has double lumen, taking blood and bringing the blood. The ECMO, it has the, the blood, they're gonna go to the filter, and then you have the, after you filtered, you bring it back, and the heart is working, so there's ventilation filter, and then connect with vents here, and then you bring it back to the baby. So blood taken away, dirty blood, filtered, as if you are kidney, and then ventilated, and then bring it back. So you bypass the lung by doing this, okay? And the heart is pumping normal, so that's function. So usually we use VV ECMO if you are dealing with interstitial lung disease. Again, ECMO, we have two types, VV ECMO, VA ECMO. The VV ECMO, we use it if you are dealing with normal cardiac function. In case of the interstitial lung disease, idiopathic closure of the ductus arteriosus, primary PPHN, any cause, diaphragmatic hernia, any cause of the non-cardiac causes. We usually use the VV. Catheter, double lumen, or dual catheter, not the dual catheter. The blood taken away, the blood come back. So taken away, filter, and then go to the vents, bump, come back, and the heart pumping the normal, okay? You bypass basically the lung. In the VA ECMO, veno arterial ECMO, you have two catheters. One the same that we use for the VV, the other for the heart. And here you have the heart and lung, kidney and lung, kind of you bypass both heart, cardiac and pulmonary. So use in condition you have PPHN secondary to cardiac, even the heart is not good, then you bypass both of them. The other modalities that systemic strategies that we use something called ibuprostanol, and that's usually by the cardiologist. We have to involve the cardiologist at this time if baby is not improved. Usually, which is the prostacyclin I2, we know it's potent IV vasodilator. Can be IV, can be inhaler. We know that the ibuprostanol stimulate the adenyl cyclase, which is in turn stimulate or cyclic AMP, and cyclic AMP block my calcium and cause the vasodilatation of the pulmonary arterial smooth muscle cells. We discussed about the mirolone. We said that there is a strategy by blocking the endothelin. We discussed about endothelin. We said this vasoconstriction. Endothelin 1 receptor. So endothelin 1 come, especially A1, attached to the endothelin A1 receptor, and that's called vasoconstriction. So you block the receptor by bosentan or besentan, okay? And that's been used in adult mainly. Regardless what you do, there is always significant risk of the morbidity long-term on babies who has PPHN, and that's very important. When you have baby with severe PPHN, you need to approach the parents about mortality and then about the long-term if baby survive. They have significant long-term morbidity like neurodevelopmental, cognitive, hearing loss, regardless how good you are. And that's the published 2007 by the pediatric. So those baby at risk of that because hypoxemia, correct? We don't know how long he's been hypoxemic, at risk of the neurodevelopment, cognitive, hearing abnormality, irrespective of the cardiac mortality. So in brief, you want to make sure that you don't want to reach that point when the baby has PPHN by having low threshold for PPHN. You manage baby aggressive at the beginning. You avoid hypoxemia and hypoxia. If my baby already developed some degree of PPHN, you need to move fast. You don't want to wait because longer you wait, harder to treat. Number one, you make the preventive measurement. You start with non-invasive and maybe you end up invasive immediately if baby is severe enough. You think that he needed. You might sedate the baby to minimize the irritation and taking stress away from the baby. You treat underlying cause. If the sepsis, if meconium, RDS, you're going to give the surfactant. The goal of the vents always to keep the low lung strategy. If you use the pressure, should be less than 25 to 28. Use the beep of 5 to recruit the alveoli, and you usually start with the rate of 40 to start. If baby does not improve, he required more than 28, or despite what you did, then potential maybe, especially if your baby on 100% oxygen, you consider add the nitric oxide based on the OI. The OI to start nitric oxide more than 20. You start with the 20 dose, 20-20. If the baby does not improve, you might switch and require higher BIP, then you might switch him to the high frequency, but you need to make sure baby is calm. Why? Because he's gonna fight with the high frequency. Your goal saturation, 90 to 95. And by finishing the summary, I think that's the end of the lecture for today. Any question?
بارك الله فيك دكتور أيمن، جزاك الله كل خير. الحق يعني محاضرة شيقة ممتعة وما خليت شيء يعني. جزاك الله كل خير. توا خلينا نشوف اذا
بارك
كان
الله
فيه
فيك.
اذا كان حد عنده اسئله. في الاول دكتور ايمن كتبوا بعض الزملاء على البالس اوكسيمتر where to put on the right hand or on the left hand بالنسبه للبري داكتل، فهذه بدك تعلق عليها يعني.
هذه قلناها، هذه البري داكتل. when we say بري داكتل that means the left hand. لأن السبكليفيان left hand not the right hand. sorry
okay.
I'm sorry I'm wrong.
right hand.
the right hand not the left hand. I'm wrong.
بالضبط، هي مشت باي ميستيك هيك، فتو الزملاء على الاقل كلهم يعرفوا بس يعني في المحاضره.
لا ممتاز. the right hand not the left hand، لأن في عندك السبكليفيان. so الدكتس before the ducts عندك شنو اللي هم التو برانشز من على الاورطه، محتاج عندك السبكليفيان كي يغطي الليفت هاند. فانت عندك الرايت هاند هذه الموست امبورتنت اللي هو اسمه فيها بري دكتال. I'm so sorry again. right hand not the left hand. I said في my lecture left hand or
ايه left hand. ايه
لا
قلت لهم
right hand not the left hand. please correct it. جزاك الله خير.
اوكي تمام. دكتور ايمن بنقول لك بس على الكومن سيناريو اللي نتعاملوا معاه في البي بي اتش ان، اللي هو لما يكون فيه باك جراوند هيستوري زي تو في الميكونيوم اسبيريشن ولا في السيفير ار دي اس ولا في اللنج هايبوبليزيا، ولا لما يكون هو فعلا الموضوع يعني in the list of our differential diagnosis. تمام. يكون البيبي الساتوريشن بتاعه is not improving ونبدو فعلا نفكروا انه هل هو PPHN or not. So as you know we couldn't summon the cardiology to do echostat stat echo, sorry. So presumptively we diagnose PPHN by the baby response to the magnesium sulfate. So we give loading dose of magnesium sulfate. If the baby is responding, that means his saturation start to raise up. So that means the baby had pulmonary vasoconstriction. So I don't know about this practice. Maybe it's just adapted because of lack of resources.
أعتقد إن هي more adapted في pediatric group they use magnesium sulfate في الأزمة. لكن يعني لم أسمع أن magnesium sulfate being used في البي بي اتش ان. لكن إذا كان ما عندكش حل، إذا كان أنت ما عندكش حل أصلاً، فتلاح just by measuring pre and post ductal saturation حتعرف إنك أنت شو اسمه most likely you deal with PPHN. إذا كان ال difference more than 10 أنت most likely dealing with the PPHN. فأنت بتمشي بهذه الطريقة دي. لو كان ما عندكش كارديولوجيست unfortunately تمشي بهذه الطريقة اللي يجيك الكارديولوجيست.
مانجمنت وايز بالنسبة للمغنيسيوم سلفيت هذا الكومن براكتس هذا الكومن براكتس.
I mean if it's I don't remember that I read one of like any of the articles that I read about PPHN. I don't remember that magnesium sulfate of the part of that.
اوكي. بعض الأسئلة
هو دكتور معلش
دكتور مصطفى
تفضل.
هو دكتور ايمن البراكتس I think before the nitric oxide the magnesium sulfate has been used before, so there is a lot of articles about it, but that's before the era of the inhaled nitric oxide. Dr. Abu Rusbafi, I think he had a lot of research about it. I think he was trained in States before, but he was an old man. And he's a Jordanian guy, and he published paper about that. So I think it has been used before the era of the nitric oxide before. But now, because there is a nitric oxide, and it's a drug of choice, so I think if you have the resources, you cannot use, but if you don't have the resources, it's actually being useful, basically. Also, it's not selective. It causes also systemic hypotension. So you will end up having also a lot of input by inotropic support and etc.
I see. عمري جربته والله. جزاك الله خير المداخلة. أنا ما نعرفهاش والله. نعرف إن في البدايات كده use it, yes. لكن I will.
Before, yeah. It has been used before the era of inhaled nitric oxide. It has been used. Another thing, Doctor, but for the cases اللي هم بيكون مثلا الارterial access is very difficult. Sometimes that can happen.
Yes.
So you will not have an oxygenation index actually for these babies.
Wallahi, I'm gonna tell you the truth. A lot of places they just jump to the nitric side even without based on the يعني زي ما نعرفوا ال UA line sometimes difficult to place the UA line. And even the arterial line is difficult. Then you don't have the option. Just use the nitric side. You don't wait. A lot of places they try to limit what's the issue here in America? A lot of places they try to use the nitric side because it's expensive. So they set this policy at least to have the clear, because people they jump, if baby hypoxemic, they jump immediately using the nitric side. And that's my opinion, that's the reason why they place the protocol and they look at the OI, they want to make sure that he has. So in my training, in both centers that I trained and now practical, I did not see anyone talk about let's do OI to start that unless you have clear policy. The universities usually they have the policies, so the people they follow those policies. But in the practice, in the institution where it's like the more private, they jump if they are sure. They do echo if they know that this PPHN. They start nitric side, especially if the baby higher oxygen required.
I agree with you. Thank you very much for the lecture. But there is something called a saturation index. And it has been used now for the past 5 or 6 years. We have been used that. So if we don't manage to have an oxygenation index, I think we talked from our pediatric intensivist, and it has been validated for neonate. Saturation index will be the same, but instead of PaO2, you will use the saturation. So like MAB multiplied by saturation divided by, MAB multiplied by FiO2 divided by saturation. And that's called saturation index. And roughly the oxygenation index equal to 2 multiplied by saturation index. So that can be sometimes useful for places who they don't have, cardiologists to do echo for them to demonstrate right to left shunt and that sort of things,
Yes, I agree, but I'm based on my practice and based on what I see here, that's more academic. OI, saturation index, V gradients. In universities, usually they use the OI, as I told you, just to limit the use of the nitric side. It's a good idea to use the saturation index if you don't have the arterial line and you want to limit, if you are in place and you don't want to limit the nitric side use. Yes, I agree with you. But majority of the places, even Johns Hopkins that I trained, they use it without even without even the OI. People, when the baby is severe, you throw everything.
No, I agree with you. I think if you got the clinical case scenario, which is going with, PPHN, you will do that.
Yes.
Thank you, really. It was very useful lecture. Thank you, Dr. Ayn.
شكرا جزيلا دكتور مصطفى، شكرا جزيلا.
جزاك الله.
هنشوف بعض الأسئلة. على اليوز اوف سلدينافيل ممكن في الريسورسز بتاعنا. الو تسمع في دكتور؟
ايه نسمع فيك معك.
يوز اوف سلدينافيل هل ممكن نستعمله كفيرست لاين؟
احنا we call the cardiologist even before they use sildenafil. So as a neonatologist, we use the nitric side. We don't take permission from the cardiologist to use nitric side. Like once start thinking about adding sildenafil or adding something else, you need to involve the cardiologist. To use sildenafil, do you guys have it oral or what's the
tablet ونديرها dilution يعني بالوتر.
I mean, if you don't have other option, I will say use it. If you don't have any other option, your baby is either way he's getting worse. So you just throw everything you can to prevent baby to go to die, basically. but I can tell you here, we don't use it as first line. Usually when we are stuck with the vents as an alternative to the nitric oxide, but yes, you can use it.
دكتور أيمن use of sodium bicarb.
So use of sodium bicarb we limit. So sodium bicarb we don't use it that often. Usually when you have the pH or the base excess more than 10, you have to treat the underlying cause. Baby maybe usually we use a fluid. Sometimes we use if the baby has electrolytes, metabolic acidosis with some electrolytes, we use a sodium acetate riders. But if you are pH or base deficit more than 10, yes, you can use the sodium bicarb. To correct the acidosis.
تمام دكتور. في سؤال ثاني على الميكانيكال فنتليتر استراتيجي. الصوت بس قطع دكتور. قلت لك على الاستراتيجي اوف ميكانيكال فنتليتر ان PPHN to induce respiratory alkalosis.
هذه old practice no longer recommendation لأن زي ما نعرفوا إن hyper or alkalosis you reduce your BCO2, correct? When you reduce your BCO2, what's going to happen to we discussed last lecture, what's going to happen to your perfusion in the brain?
Hypoperfusion.
You decrease your blood perfusion, correct? Blood flow to the brain, correct? So that can cause worsening. So that's why there's no longer, it's become old-fashioned, no longer recommended. Alkalinization or hyperventilation dose. Alkalinization or hyperventilation dose no longer used.
اوكي تمام دكتور ايمن، بارك الله فيك وجزاك الله كل خير. ما عنديش اي سؤال اخر.
اوكي
شكرا جزيلا.
جزاك الله كل خير.
خيرا. اهم شيء التسجيل دكتور، محاضره ممتازه.
ان شاء الله ان شاء الله باذن الله.
ان شاء الله.
جزاكم الله خير.
شكرا جزيلا.
شكرا دكتور. شكرا.
بارك الله فيك دكتور، جزاك الله كل خير.
ان شاء الله جزاكم الله.